complete the meeting as well. So it is available right now, but if for some reason we would get kicked off by YouTube or any other thing would go wrong, we won't be putting it back up. We will just post it afterwards. So just so the listening public knows that. So today at our health board meeting, we have our health board members, myself, Amy Leone, I'm the city manager, Mayor Nathan Johnson, Dr. Mary Milroy. We also have ex officios, Brad Beese, our community development manager, Dave Mingo, our community development director, Jason Foote, who's commander in our police department, and we are still awaiting our city attorney, Ross Denherter. So I'll be texting him and he may pop up, but he's also an ex officio. Very special guest today, and I want to get to her right away. I'll let her tell us a little bit about herself, but we wanted to tap into a little more expertise as we talk about this pandemic and our recommendations to the full elected body. So Mayor Johnson was gracious enough to, I don't know where he found Dr. Specker, but he suggested her to me, and she was very generous to be able to give us some of her time. So we're just really excited, Doctor, to have you visit with us and can't wait to learn from you.
Thanks. It's nice to be here, I guess, under the circumstances. So I have a degree actually in epidemiology. That's the study of epidemics, so kind of relevant now. And when I first gave this talk, it actually was back in March to this service organization up in Brookings, the Altruza group. And we talked about the 1918 influenza outbreak, and then also how COVID looked at that time like it might be something equivalent. I would say now that it definitely looks like it will be something along the same lines. But as an epidemiologist, you know, for about 40 years now, I've been teaching epidemiology and doing a lot of epidemiological research. And the outbreak of 1918, the influenza outbreak then, is something we cover in all of our classes. And I think it's interesting to look at how the two compare. These are just some of sort of the vintage pictures from 1918, and then also of South Korea, and with this pandemic, and Hawaii, sort of trying to tie in, you know, how sanitation crews back then sort of approached the pandemic. And then when I first did this presentation, there were, I think, a couple cases in the United States, but most of the pictures were from South Korea or China. And since then, I've added some of the US pictures. This is the healthcare responders back in 1918 versus what it looks like now. Also, the sort of classic picture that you see a lot if you're at all interested in the influenza of 1918, this picture on the left, you know, and there's a lot of similarities now with this pandemic. The thing about the 1918 outbreak is that it started in the spring of 1918 when there were 100 cases identified in Fort Riley, Kansas. And this is a period of time where they didn't know what viruses were. So they, that kind of became important, sort of, but I'll get to that in just a second. There was this hump originally here, and then it plateaued out, and then it came back in the fall of 1918, died out in the spring and summer, and then came back again in the early part of 1919. Oops. About a third of the world's population was infected, and there were at least 50 million deaths worldwide. 675,000 occurred in the United States. And the thing that's different about the influenza of 1918 and the current outbreak was that that pandemic really affected the 20 to 30-year-olds. You know, that's where they saw the highest mortality rate. But it was a fatality rate of about 2%. And when I say fatality rate, that means of the people who get the disease, what percent of them actually die from that disease? So why were so many people affected back then? Well, it was a new virus. We know now that it was H1N1, and that's why everybody was so worried back in, I think it was 2009, with the H1N1 outbreak, because a lot of people had not seen it in the populations for a long time, so there was no immunity to that. But back in 1918, it had never been around. It was brand new. So there, no one had any prior immunity. There were no vaccines back then. So the control efforts were really limited to non-pharmaceutical interventions. And they weren't really applied because that was World War I. So there was a lot of parades going on that people were going to. There were a lot of bond drives. You had the military, you know, shipping a lot of young men over in boats, kind of crammed full of people. You had them in the ditches, you know, fighting the war. So there was a lot of spread of this disease. So that really didn't happen. You didn't have a limiting of the public gatherings. And we'll get back to that in a second. The coronavirus infection that we're seeing right now is more than just the common cold. And I think this is important to realize. The coronavirus is the virus that causes the common cold, but it's the ones listed here in the second bullet that account for the majority of the common colds. And those coronaviruses really affect the upper respiratory tract. Okay, there's 3 coronaviruses that affect the lower respiratory tract. That's the SARS virus, which came out in 2002. 20 to 30% of the people who had that disease ended up on a ventilator. It had a mortality rate of 10%, and there was human-to-human transfer. So this was a new virus back in 2002. 2012, we have the MERS coronavirus. As of 2019 in November, there were about 2,500 cases worldwide with almost 900 deaths. So it has a much higher mortality, but there's no human-to-human transfer. This particular virus has to be transferred from animal to human. And I think one of the big reservoirs for this are camels. So you see a lot of this disease in the Middle East. That's why it's MERS for the Middle East respiratory virus. In 2019, we now have the SARS coronavirus 2. This is the one that causes COVID-19. It was identified in Wuhan, and there is now known to have human-to-human transfer. And just to give you an idea about these 3 viruses, this graph or table was made back in the beginning of March, when only there were 72,000 people in Wuhan with the SARS-2, the virus that causes COVID. And you can see that the mortality rate in Wuhan was significantly lower than SARS and MERS, but it was causing more deaths because it's highly infectious and it is easily spreadable or transmitted to other people. At this point in time, China was the only country thought to have SARS-2. And right now, the World Health Organization is estimating that the mortality with SARS-2 or COVID is 3.4% or 3.5%. Here's what's happening in the world as of yesterday. There's about 2.5 million cases. Over the same period of time, there have been about 184,000 deaths. And I think it's important to remember that you can't just take the number of deaths and divide them by the number of cases to come up with what the mortality rate is. because there is a delay in the deaths that occur with this disease, with a lot of deaths typically occurring 7 to 10 days after the diagnosis. That's kind of the critical time. The numbers that are on this graph, the first 3 numbers down there in the bottom, those are the numbers of cases worldwide on the 1st of February, the 9,800. March 1st, there were 87,000. April 1st, 927,000, and now 2.5 million, not even a month later. If you look at the United States, this is the same period of time. There have been about 844,000 cases with 47,000 deaths, and you can see the curve here really starting to take off towards the end of March. If you look at the South Dakota situation, as of today, there have been 9 deaths. Well, actually, this was posted today, so as of yesterday afternoon, there were 9 deaths, 58 currently hospitalized individuals, close to 2,000 positive cases, and I also list here 12,000 tests that have been run that have been negative. Now, when I talk to people about this, a lot of them say, well, that's just Sioux Falls. So if you break it out, these are the numbers for the Sioux Falls area. In yellow, that's Lincoln, Minnehaha, McCook, and Turner counties. And then this orange line down at the bottom are for the rest of the state, not Sioux Falls. And as of today, there are 193 cases outside of the Sioux Falls area and about 1,700 in the Sioux Falls. And that last slide, you don't really get a good feel for the increase in the areas outside of Sioux Falls because of the scale of the axis. But this is showing that we are seeing a steady increase in the cases across the state. I've worked on some prediction models, and we're seeing that it looks like it's going to peak outside of the Sioux Falls area sometime in June. Sioux Falls may actually reach their peak a little bit earlier. These are the number of deaths, and they are, I think, going to be really increasing within the next week based on the previous slide when I said there's 7 to 10 days between the time of diagnosis and the time that you see the deaths. So there is this lag. So I expect these numbers to be going up in the next week. Looking at Yankton, I left out like kind of a chunk of numbers there on a lot of these graphs actually. And that's because the numbers didn't make a lot of sense to me because they went down and then back up for Yankton. So I just put where I thought it made sense. There were 2 cases identified in the last 24 hours. And so now Yankton has 25 cases, 4 of them are active, 21 recovered, no deaths, 1 hospitalization, and the state considers this county to have substantial community spread, meaning that people who have the disease are not ones that traveled somewhere and got it and then came home. You know, they're getting it within the community. So it has been going up. And you were flat for a while, but it's gone back up. So back in March, I sort of came up with this, not doing any sort of model because we didn't have the hospitalizations that you need in order to develop a model. This was just sort of off the top of my head. How can I guess at what this means for South Dakota as a state? And so at that time, back in early March, Wuhan had a population of 11 million, and they had found that 0.7% of their population developed or tested positive for COVID. And I think that's something we should talk about a little bit too, is the testing and what percent of the population's asymptomatic. But so they had, about 1% of their population testing positive at that time. With South Dakota's population of 880,000, and there's 2,700 hospital beds in the state. So, back then in early March, I'm trying to figure out, is this going to be a problem for South Dakota? If there was a 1% of the population of South Dakota getting this disease, there would be 8,800 cases. Based on the Wuhan data, 20% of those cases would be severe or critical, which would give you 1,760, which, you're getting close to what you might be able to hospitalize within the state, assuming a lot of those elective surgeries and hospital beds were empty. Based on that 1,700, if you look at the mortality rate from the World Health Organization, that's going to be about 300 deaths. If you look at the estimates coming out of Wuhan, where they found 20% mortality of those severe or critical cases, you would expect about 350 deaths. Now, if you go up to 5% of the population, you can see this will definitely overwhelm the healthcare system, and the number of deaths would be 1,500 based on sort of these guesses. And these are guesses. There's models out there now that are predicting, some using a little bit more complicated methods than sort of these guesstimates that I tried putting together back in March. And I keep this slide up because I'm curious where it ends up, like what this sort of more simplified approach comes up with. So why are so many people being affected with COVID? Again, it's exactly like the influenza of 1918. It is a new virus. No one has any immunity to this virus. There are no vaccines for this now. And the control efforts really that need to be applied are the non-pharmaceutical interventions, where you isolate cases and you quarantine people that are exposed. Good personal hygiene, the use of disinfectants and hand washing, and then limiting the public gatherings or social distancing measures. It really is important to slow down the spread of this, because you have to flatten the curve. Mainly, if you flatten the curve, you're going to draw it out. More people, you're going to take that peak and move it to a later point in time, but the peak is much lower. And by having a lower peak, you're not going to overwhelm the healthcare system or the healthcare providers, or the ventilator access, which is becoming an issue, and how many medical providers are in the state of South Dakota that can really handle people that are on ventilators. That's not something that a general practitioner can do. You need to have experienced physicians who know how to intubate people and then how to maintain them on these ventilators. It's not something that a lot of people can do. And I think that a lot of people in the public don't realize that that requires special training. So that's really what I have for a presentation, and I'll be happy to answer any questions you have that I can answer.
Yes, thank you very much. Very informative. Just great information. Question that I have for you is, I'm sure you're aware that many of the communities in South Dakota have put into place ordinances, including Brookings, by the way, to slow the spread. So these ordinances limit gatherings, they limit events, they put in social distancing measures. They've, in fact, restricted restaurants to carry out only service, bars, etc., limited to off sale carry out. Also, where you're in close proximity with other individuals. So hair salons, nail salons, spas, etc. Those have been closed. That has been going on for about a month. And, I think that it's helped us limit contact with people. In your opinion, should those measures continue, or should they, are we ready to open back up here now that Sioux Falls is starting to peak?
I don't think so at all. I mean, I don't think that we have seen the worst of this yet. None of the projections we've been working on indicate that the worst has been here. All of this is going up. And I guess if you look at, there's one way of graphing these data where you have the number of cases diagnosed each day. And usually you'll see like a curve for something like that. But we see it go up, it's down, and now it's coming back up again as far as the number of cases diagnosed per day. So we are definitely not on the decline. I don't think so. There's nothing that I've seen that indicates that this is slowing down at the moment.
Okay, great.
I think the Sioux Falls data, with Smithfield, that's a chunk of that data. But if you pull out the Smithfield cases, and I don't know how to do that because I don't know which ones are Smithfield exactly. But if you look at the background in Sioux Falls, I would bet that it is going up just like it is in the rest of the state, that one curve.
Okay, very, very helpful. Thank you.
Yep.
Dr. Specker, this is Dave Mingo. So if it's advisable to wait until the decline or the beginning of a decline to reopen, how would you time that? Would it be right when we peak that you consider reopening, or would it be 2 weeks after peak or a month after peak, or does it depend on how fast we start declining before you make a decision or a recommendation like that?
I would think that first you have to have, I think it has to be in the decline and not at the peak, because when you're at the peak, you have the most people with the virus that's out there. Now it's now probably good to mention this other thing, some other things that have been discovered about this virus. In the last week, there have been 2 reports, one from Italy and one from Iceland, where they have tested a significant number or percent of the population for this virus. And what they have found out is that 50% of the people who are testing positive, it's actually, I think 43%, close to 50, 43% of both populations in Italy and Iceland that have tested positive have absolutely no symptoms. Those people are capable of spreading this disease to other people who are maybe more susceptible or may show the symptoms. So I think it's, you have to realize that just because someone hasn't been diagnosed, that doesn't mean they don't have it. The testing right now in South Dakota, you have to have a pretty severe case in order to be tested for this disease. So you have people who don't know whether they might have some of the symptoms, but they don't know whether they have it. They haven't been told to self-quarantine or isolate themselves. And then you have a chunk of people about, based on these other studies, there's like double the number out there that actually have it that you don't even know about and they don't know about. So the social distancing will help prevent the spread in that situation. So I think you definitely have to see it going down. But even then, I would phase it so that you still are encouraging people to stay 6 feet from apart. Some of the social distancing recommendations that are a little bit more easier to implement when you start phasing out some of these restrictions might be the way to go. But I think that you need to be able to put the restrictions back on as quickly as possible. I mean, that was what I thought was a nice thing that Brookings just recently did. They had that stay-at-home order, and I'm not sure if this is a state law or what, but you have to have 5 days between the readings of the two orders. And so they wanted to go ahead and have that first order so that if things did start accelerating, they could implement it quickly. And if you think of that graph, earlier, further back, what happened in Sioux Falls here, I mean, within a week, you increase this almost by 1,000 cases. I mean, this can really blow up quickly. So you need to be able to do something quickly. So I thought that was an excellent thing for them to do as far as being able to implement a stay-at-home order like tomorrow if they felt that they needed it, rather than having to wait 5 days, because a lot can happen in 5 days with this disease. So does that help?
Yes, thank you.
Do you have some suggestions on effective ways to phase things in? What businesses or what people, what steps are best to take when we do start making a plan for opening?
Well, I think some of the things that I've seen that appear to be effective, it might be too early to say that because they're just starting to do this, but some restaurants may have like limited seating with more distance between the tables. That could be an idea. Anyway, I mean, I only know of things that have happened in Brookings too, where, say, the liquor store, implemented a policy of they limit the people in there, or you call your order in ahead of time and they have it right there for you so people don't have to come in. The golf course has implemented some, I thought, pretty creative ways of maintaining social distancing, but still being able to have the golf course open. So I think it's up to a lot of places to come up with ways of opening businesses in a responsible manner. We have several stores in Brookings where they've started selling things online, and then you can order the stuff online, you pay for it online, you drive in front of the store and they'll come and put it in your trunk. So I think there are ways to be creative about this that would help a lot and might be a good way of, kind of letting up on some of that.
How are you handling some of the businesses such as hair salons, dog groomers, things of that nature?
I think hair salons are still closed. The problem with hair salons is you do have fairly close, you have close contact between the person cutting the hair and the client, and they have a lot of clients in one day. So if you have a client that comes in as asymptomatic, gives that virus to the person working in the salon, and then they are now spreading it to all their clients, that could cause a major outbreak. So I think salons, maybe just let everyone, have their natural color and shaggy hair for a while. I think that's a lot better than being an outbreak that's associated with deaths or severe illness. I don't know how many beds you guys have. How many do you have at the hospital there? And do you have ventilators?
We're licensed for 99 beds. at the hospital in Yankton, but we're planning for a surge that would far exceed that at this point.
Yeah.
And I guess we're not really, I happen to work for the hospital, and I guess we aren't really saying publicly how many vents we have, but we do have a supply.
Yeah, and I think, but you still have the issue of whether or not there's sufficient healthcare providers there to staff, a surge like that. And I just think it would be really bad to get to the point where you're having to decide who gets ventilators and who doesn't. And because the healthcare providers are now sick with this, and you don't have the ventilators or the hospital beds. And it's not Yankton. I mean, it's the state we're talking about. It's not just a local thing. To me, the social distancing is so important because you can handle something that's not all at once. You're still going to need people on ventilators, but it's going to be more of a trickle rather than a tsunami. And I don't know if people realize how important that is. Yeah, it means things may be closed, or these inconveniences may last a little bit longer, but in the long run, it's, I would prefer to get my immunity through a vaccine in a year from now than getting this virus and being as sick as it can make some of the people, or getting the healthcare provider that cares for me sick. So
I was wondering if I could ask a follow-up from Dr. Milroy's question, which is I've been trying to read a little bit about those places that are beginning to do some easing. Maybe they're in a different place in the curve, or whatever the purpose is. I'm just trying to understand some of the mechanisms and procedures they've put in place. And in looking at those close contact sort of businesses that she mentioned that are difficult to distance, that there's really no reasonable, or it's a very challenging thing to figure out how you would distance. It looks like they're beginning to implement some of the OSHA CDC requirements about spacing, waiting areas, maybe requiring waiting outside by appointment, wearing face coverings until PPE is more widely available, an increased disinfecting sort of regimen. What do you think about things like that in terms of phasing in those interactions that are challenging and difficult and can't really do a curbside sort of thing?
I don't think now is the time to do that, but when it's done, I think those are good approaches. But I also think it's important to realize that the face masks protect other people, not the person wearing it necessarily. And if you have, which is good, I mean, that's a good thing to implement, because that person may be one of those 40% that have the virus and are asymptomatic, and they will help decrease the spread by wearing that face mask. But it doesn't help you not get the disease. I just throw that out there. So, but I think the 6 feet distance between people, and there are quite a few places that are starting to loosen up. Again, Iceland is a good example of, they never closed their elementary schools. I mean, they had a lot of cases, but I think they had a lot of cases because they tested so many people. I think we would have a lot of cases if we tested people. But they're limiting their gatherings to no more than 20 people. And this is part of their phase in to sort of up it just a little bit and see what happens, like leave it that way for a couple weeks, see if there's new cases that start developing that they could then back off of, this. So I think it's definitely something that you want to do gradually.
Dr. Specker, maybe you can add historical perspective to this. So I think what we're seeing now is something they might have experienced in 1918, where, in South Dakota, we are behind the coast in where this disease is at as far as the spread. And so I think that's creating a bit of a whiplash effect for some of our residents, where they're looking to the coast and they're saying, oh, things are maybe plateauing in a lot of those problem areas. Yet we're telling you that in South Dakota, the upward trajectory is still ahead of us, and the weather is getting nicer. And there's a temptation to think that the worst is behind us here. And we have a naturally optimistic view, or we are optimistic in our outlook in a lot of cases. How do we counteract that and get people to be realistic and continue to adhere to the social distancing advisories?
I think in just letting them know that we aren't past the worst part, and we are definitely behind the rest of the East Coast and the West Coast. There are animated graphics out there that show the spread of this, and it within the United States, where it's kind of lit up on the coast and then it's sort of gradually moving in. I think if they looked at some of that, they would realize that we're behind the rest of the country in a lot of this, and that what is applicable to New York may not be applicable to South Dakota at the moment. I mean, I always said I like living in South Dakota because we were behind the rest of the country. So when you're raising kids, that's kind of nice. But it applies to this too. So we are behind. And maybe that's good, because we can see what New York does when they start loosening up their restrictions, and see what works for them and what doesn't work, and use some of those lessons learned here when and the other thing too, and this is, I think, something that's good to remember, that peak that everyone keeps projecting, it would be really nice if that peak didn't occur and someone were to say, well, your whole projection was way off. And it's like, well, good, because that projection is based on 25% social distancing, that 25% of the population is going to adhere to it. If more of the population does, then that peak is going to be even smaller. And the smaller the peak, the more successful or the better people have been. So yeah, prove me wrong on projections by doing a good job at social distancing and not having a peak. I mean, that would be a great outcome. Does that make sense?
I think part of the struggle here is, our conversations are happening on different levels. There are different ideas of what success looks like, because you have those individuals who say, well, just let the virus run its course and whatever happens, happens. Then you have those who maybe on the opposite end who want to shut everything down. And then there's the people in the middle who are willing to accept different levels of economic shutdowns. And so when your ideas of success are different, then you have different acceptance of the economic pain that comes along with these social distancing measures. And I think a lot of us are just struggling with that, with the social and political and economic realities, versus if we were just looking at it through a purely epidemiological public health perspective, our answer might be different. I certainly find myself wrestling with those issues.
No, I think that is understandable. I mean, it is affecting a lot of people economically. But I agree to some extent well, I don't know if I agree, but when people say let it run its course, the advantage to that is eventually you need a good chunk of the population to be immune to that. But by saying right now, let it run its course, you are going to make so many healthcare providers sick. That's going to increase the mortality. I mean, the healthcare providers are one population that have the highest mortality from this disease. And you're going to be making someone decide who lives and who dies, including you, the person who's saying, let it run its course. I mean, if you're willing to say, sure, let it run its course, and I won't take someone's ventilator, or I won't go to the hospital and get the healthcare provider sick. I mean, it's just, you don't need to do that. You can let it run its course over a longer period of time, and by getting vaccines that will protect you and not require having exposure to the actual virus. I think another thing that you could consider or remember, and we have done this with the curves too, is looking at vulnerable and non-vulnerable populations. You know, can you, when this starts, say when we think we're past the peak and things are going down, enforce this or recommend the social distancing for vulnerable populations, you know, the people over age 60 that have and people that have comorbidities. So the older individuals and people with comorbidities at all ages that are associated with increased risk of serious outcome with this virus, you know, maybe loosen up on the non-vulnerable population before you start recommending it across the whole population. So, I mean, I'm a vulnerable in that vulnerable population, and I can assure you I've been locked in my house for 3 weeks, you know, except when we go to the grocery store and get it brought out to the car because we ordered it online. And, you know, we'll continue to do that. Probably after Brookings lets up on the restrictions, just because we are in that vulnerable population. So I think that might be one way of trying to ease off, is by looking at the different at-risk groups.
And as far as at-risk groups, rural areas like South Dakota, where we have a larger percentage of elderly, you know, could the virus play out differently here versus, I know there are a lot of factors. We're more sparsely populated, but we're also older. And I think generally rural populations are in poorer health than metro areas.
I'm not really sure about that, but you know, there is a high rate of type 2 diabetes in South Dakota. That's a major risk factor for poor outcomes with this disease. I think the distance, not so much Yankton, but the distance in healthcare access is going to be an issue. Yeah, I think we do. I know we looked at the vulnerable and non-vulnerable populations or projections first, and if we look at Sioux Falls and outside of Sioux Falls, like Sioux Falls, actually, their curves differ from the rest of the state because it's a younger population in the Sioux Falls area. So that applies, you know, the projections take into account the age distribution of the population, not just of the state, but if you're breaking it out by Sioux Falls versus other regions. So yeah, I mean, age is definitely a factor. So.
And I think what a lot of people lose sight. They may be thinking, well, once we get past this initial peak, then we can relax. But as we were reminded this week by the CDC director, the fall could be even worse. And that was something that you mentioned they saw with the flu epidemic as well, or pandemic, I guess, in 1918.
Yeah, I'm not sure if those two things are comparable. I'm not sure why the flu of 1918, the second peak, was so much worse, unless there was less social distancing or it had just spread further. I think what the director of the CDC, at least from what I heard, was implying is that you get it in the fall, you're now doing it on top of the flu season. And the flu season, you're already kind of testing the health care system with the hospital beds and the ventilators. I mean, it's the diseases cause the same type of problems. So you're going to be really maxing out your resources by next flu season. So I'm not sure that was the situation for the 1918 influenza. But it's more that if it does come back if it does follow that pattern and you put the demands on the healthcare system on top of what the demands are as a result of the flu, then that's going to be problematic.
And as part of your studies, have you looked at human behavior when it comes to stay-at-home orders, those types of things? Because I've heard some about, how people are willing to do it for maybe 2 weeks, but after that they let their guard down. Do you have much science around that?
I really don't, and I'm not sure if I don't remember seeing anything on that. I do know, that here we've had these stay-at-home orders for over a month, and I mean, I shouldn't say I haven't left the house because we do have a bike path that I go on just about every day. And on that bike path, if you're coming up to someone, people are putting 6 feet apart from each other when they're crossing, like they're on the bike path. So it seems to me that people have maintained a seriousness about it, at least up here. And it could be just this neighborhood. We have a lot of old people in this neighborhood, so a lot of the students are gone. They might not be maintaining that seriousness as much as the rest of the population. But
so if you had to sum up your advice to local elected officials right now who are making the decisions on ordinances like stay at home, or at least they're limiting certain businesses, how would you sum up that advice to them?
I'd say make social distancing a priority. I mean, that's really the way of doing it. I don't know if and I can send this along, the link to it, but the state of Ohio has a really nice advertisement that just came out with this ping pong ball and the mouse traps. I don't know, anyway, imagine a room full of mouse traps, right? And ping pong balls sitting on each of the mouse traps, and the mouse traps are right next to each other. Ping pong ball hits it, and then they all start going, off at once. You spread those mouse traps apart, throw a ping pong ball in there, and it doesn't hit any of them. And that's sort of how social distancing works. It's a great visual for getting that across. There is a thing in epidemiology, this reproductive number. How many people do you expose or infect if you have the disease? Measles, that reproductive number, something like 14 or 15. So if you had the measles, you're going to infect, say, 14 or 15 other people with that virus. And that's what makes it so infective and spreads so easily. This particular virus has an infective rate of between 2 and 3. So if I'm infected with the virus, I'm likely to give it on average to 2 to 3 other people. Well, and then you start building that, you know, those 2 to 3 people are going to give it to another 2 to 3 people, and you can see how these numbers really take off. That number needs to get below 1. You know, if you're giving it less than one other person, then the disease will fade away. The only way to do that is to stay away from people, to not give it to them. So that's what social distancing does. And I think the face masks help a lot, because if you are asymptomatic, you're not spreading it by the droplets. When you go into the grocery store, you know, where you might have to be closer than 6 feet to someone, that blocks your droplets from getting into other people's safe space. So I think that would be good to help spread it. It doesn't help prevent you from getting it, but it helps the population. Worry about the population, not yourself.
Good advice. Does the health board have other questions for Dr. Specker? Otherwise, of course, she's welcome to stay with us as we continue on with our discussion and our agenda, but I want to be respectful of her time as well. Other questions? I'm looking for mics that might turn on.
I just really appreciate you taking the time to be with us today, Dr. Specker. I had been reading about Brookings City Council and saw that you had provided some information to them. So thought it'd be useful to us to have a state epidemiologist or an SDSU epidemiologist visit with us about your expertise. And so it has been very helpful. Thank you.
Thanks. I hope things work out good down there.
Thank you.
I just want to say thank you also. That was very, very helpful, good information. So thank you.
Thank you.
Okay, thank you so much, Dr. Specker. And like I said, if you want to stay with us, you can. Otherwise, go ahead and log off, if you will. I do have your presentation to share with other folks if they ask for it.
Okay, thank you. Have a good day.
Thank you. Well, I think that was a great opportunity for us to look a little deeper into what we're dealing with here. We are charged with making a recommendation to the City Commission for Monday, and we can visit today, and we also have a meeting on Monday. So, you know, a lot can change in numbers, but just curious what everybody's initial thoughts and responses are after hearing from both Dr. Basil and then Dr. Specker today.
I guess what I'm hearing from both of our speakers is that we need to be very cautious about kind of letting off some of the recommendations. I know that at City Council, that will definitely be the question. And I know there's people that are definitely, I mean, feeling a very severe economic impact and will be kind of pushing to get things open as soon as possible. But I guess as we look at what is going to be safe, I guess right now, looking at the projections and the curves, I would be inclined to make a recommendation that the City Council extend their ordinance, you know, at least another 1 to 2 weeks and watch it closely. I kind of liked the idea about Brookings even making the first reading, so if they needed to jump back on. So I think when we do get to the point where we are willing to say, hey, let's give this a try, that having that first reading, so you have it so that if things do start ramping up, you can be nimble and act quickly. I liked that suggestion. It might be something we could bring up to the City Council.
Yeah, that's something we can take a look at. Mayor or ex officios, what are your thoughts?
Well, I guess from the health board perspective, I think what we've been told is clear. If we're looking at this from a public health perspective, I think we would have to recommend to extend the ordinance as it is for, I would say, at least 2 weeks to see where the peak trend is heading. That being said, I know there are other considerations that enter into the equation for the commission, where they're balancing economic impacts with the public health impacts, and I think I think politically we'll have a hard time getting them to approve an extension of the ordinance as it is. But as a health board member, I think the recommendation from this perspective is clear. That may sound convoluted, but I think it makes some sense.
Ex officios, based on, your experience, knowledge, what you heard, where are you guys sitting?
You drive up and down the streets in town over the weekend, and the community was definitely busier. So I'm curious to see, like I said last meeting, what impact that has on our trends. One of the most impactful things that Dr. Specker said to me said to us, and you have trouble putting this in context because it's kind of a doom and gloom comment, but when somebody in that position says, hey, if we just decide to cut loose and let the virus run its course, are there people then that are willing to say they won't use a hospital bed or a ventilator because that was their opinion of how we should approach or the strategy to deal with this issue? And I mean, to me, that's a very powerful statement. And of course, you wouldn't ever ask somebody to sign a contract saying they weren't going to use a hospital bed if they needed it. But the reality is that if we pull that curve closer to us, it's going to go a lot higher, and that is going to push our need for hospital beds and ventilators and other supplies. So I don't know how at this point the health board could do anything else other than make a recommendation to at least go a week or two, as Dr. Milroy said, because the data is changing every day. That statement really kind of put it in perspective for me.
I guess in terms of maybe not timing, but in practice and policy, because the reality is some folks are open and some folks will be open, and we don't have a zero activity going on right now. So in terms of thinking about mitigation and long-term practices, it really specific things folks can do. I read the report that came out of the CDC report that came out of Smithfield, which is obviously a very specific facility. But the one takeaway from that I think is valuable for every organization and every business, public entity, every building that has people come into it, HHS and the Department of Labor through OSHA has put together a 30-some page guide for guidance on preparing workplaces for COVID-19. Nothing in there is particularly revolutionary, but it's very specific guidance. And from an education standpoint, at some point we will be open. Most places will phase opening, and there's a lot of good things in there that I think are good in the short term because they stop the spread right now, but they also have the impact of maybe avoiding or limiting what might be a bounce up in the future. So I would encourage us to encourage, for whatever that's worth, sort of access to and information about these guidelines that are relatively easy to incorporate. And they include a lot of simple stuff like making sure hand washing and hand sanitizer is available, using educational materials, talking to staff and customers, decals on the floor, waiting outside. I mean, lots of things that are not, again, revolutionary or new, but they're in one place and they're easy to understand, and you can apply them in nearly every workplace, nearly every gathering place.
Another reference that may be real helpful is that yesterday, the governors of many states got together and published a roadmap to recovery, which had a 10-step plan of kind of benchmarks you should meet as you go forward in a kind of a planned, systematic way. I thought that was really an excellent guide, and we should kind of look at that and use maybe some of those as some of our benchmarks too. And I would recommend that to the city council to look at as they make some of these decisions.
I agree with everybody else as far as what's going on. I think, again, you look at Beetle County, they haven't had an increase again, so I think that puts them about 20 days out. We just had another increase of 2, and I don't think we can or should recommend any changes because we haven't hit that plateau where we don't have any increases. Even though it's only 2, we're still going up, and it might be every couple days, but I think that's where we got to be cautious, because if we let off the brakes here, all of a sudden that peak hits up higher, as Dr. Specker was saying.
I think there's a lot of magical thinking in the air because of our inclination to be optimistic, and yet we've heard from 2 healthcare experts or epidemiological experts this week who have been very clear and I think consistent on their messages about what this virus is, how it spreads, and as much as we want to believe that we can just change things and the virus won't affect us here like it did elsewhere, I don't think that's reality, unfortunately. And so it's something a lot of people are really going to have to wrestle with.
So this is Ross, if I may, just for a moment here. Dr. Milroy indicated that Brookings was onto something with their idea of doing a first reading on an appropriate ordinance and then just leaving it sit for a time when a second reading is necessary. I'd just like to remind this group, if there are quite a few changes we can make to our existing ordinance just by passing a resolution, which wouldn't require a first and second reading. Although I understand the limits of what we can and can't do, and to the extent that we want to impose some across the board restrictions on how opening might occur, that very well might require a new ordinance. But in terms of kind of letting off the gas when the time is right, a lot of that can be done with just a single meeting.
Ross, what are your feelings about what you've heard today and Thursday, or Monday and today?
Yeah, having heard the epidemiologists, I don't think that it makes any sense yet, based on the data we have available to us, to recommend to the commission to release any of the restrictions. But I also understand the political realities affecting the commissioners. So I think it's appropriate for this board to take whatever action or whatever recommendation the voting members of the board think are appropriate, regardless of what the commission will do.
Yeah, this is Amy, of course. So what I'm hoping is that, I mean, at least for me, I'd like to watch the data even yet tomorrow and Saturday, Sunday, because that can change the story a lot. I'd like to make our final recommendation to the commission on Monday. I'm hoping throughout that work session meeting at 6 p.m. on Monday that the public can listen to and participate in, as well as during the discussion where the commission may take action on the ordinance at 7 p.m., that the direction we get is a general sense of where they want to go, and they can set a special meeting before the 1st of May. So maybe the following Thursday, that we can then make alterations to the ordinance if they ask us for them. If not, most of the items in the ordinance expire May 1. So in order for action to be taken by resolution, they'd need to call a special meeting. And I think it's important that we have a full discussion, a thorough discussion in public with the full commission, so we understand where everybody is. From a health board perspective, and again, I don't know if the other two members are ready to make a recommendation. I'm needing to give this, for me, a lot of careful thought and prayerful thought, because I think there's a lot of, this decision, as this recommendation, deserves a lot of levity. And I understand all the political pressures. I have my own political pressure too, because I'm making a recommendation to the people that employ me. So that's an interesting dynamic too. I don't know what's more important than your health. What's more important than our community's health? What's more important than our family's health? Our officers' health who are out there every day? That's what I can't get past, even though I understand and know that this is more than impacting people, it's crippling people. I have people close to me who have lost their jobs, and it's tough. So it's with a great amount of empathy, and I think this decision, this recommendation, needs a lot of discernment, not just on the political aspects, but what's morally right here to do and to recommend. For me, that's where I'm at, and what's right for our community. So, if the other two board members are ready to make a motion to make a recommendation to the commission, I'll pass it along to the commission. But I'm not, I feel like a couple of days data in this could make a big difference as to where even the whole community sits.
I'm in agreement with that. I think we have the opportunity to see what Yankton will do over the next couple of days. And even when we meet at 2:00 on Monday, we should actually have Friday, Saturday, Sunday, Monday's numbers released. And I think we'll be in a better position at that point. But I guess my thought too is I certainly understand, the pain that so many people are going through with the economic crisis. But I think our responsibility as health board members is to make a recommendation based on the best science and health. And then the commission can weigh what they want as far as economics from that. But I think our charge is to make a health-based decision. And I think that's how I will make my decision. But I agree, Monday is fine.
It's like we're kind of in a situation now where you have the experts telling you that the worst is on the way, and under in what situation would you have people who are the best equipped to tell you what lies ahead of you, tell you that the worst is ahead, and then you would say, yeah, but I've been doing this for a while and I feel like it's time to just let loose and get back to life as normal. That's kind of where we're at right now, where we've been making the best decisions we can based on what we know at every step of the way. And, hopefully that has led to the outcome we've had, where we've had low numbers of cases here. But some people also see it as us being overly, that we overreacted. And we knew that was coming. We said that from the beginning. If we do this right, it will look as if we overreacted. And that's the catch-22 of all this, is that you'll never know what would have happened if you did nothing. So you have to trust what the experts, the people who have studied viruses and how they work. So yeah, I'm in agreement with what everyone has said here today, and we'll continue to make the best decision we can based on the evidence in front of us. And we'll do that. I think we should wait until Monday to do that when we have even more data.
Yeah, of course. And you know, Mayor, that regardless of what the commission, where they choose to go, once the vote is taken, the staff will get behind it and support it, regardless of, you know, where that ends up. And I'm sure we'll have conversations with many of them individually here in the days ahead. But yeah, we'll definitely support that and follow through regardless. So yeah, I would encourage folks that are watching this or did participate by listening to the live stream, you know, to communicate with us. I know you've gotten some calls, Mayor, from folks on either side of the issue, and as have I. But it will be important to have that input, and we'll have a great discussion. I think talking about it for that full hour of the work session prior to the meeting will give an opportunity for a lot of people to talk through the issues and talk about where they may stand, and not something easy to decide, that's for sure.
And I think for the health board's benefit, we should mention that on Monday night, Avera will have some projections for what they expect to be the case for the Avera Sacred Heart region. So what we would see here very locally, and not just within Sioux Falls and outside of Sioux Falls more generally, but more specific to Yankton. And Doug Eckeren, the CEO of Avera Sacred Heart Hospital, will be joining us to share that information and provide some perspective that way. So again, we'll be getting as much data as we can.
Yes, thank you. And I intend to, Doug Eckeren has said that I can include that in the packet. So when that is available to me, I will have Colleen upload that in the commission packet. Dr. Specker's slides from today will also be in the packet. I've also put together sort of a little synopsis of what other cities are doing. I am hearing a lot of first-class cities in the state are having these same conversations and same struggles. Some put in resolutions or ordinances in place and they've had no cases. So they're getting the idea that they should maybe open back up. So we're not unique in this struggle, but I will have as much information as I can in that packet. And that's on the city website under city commission meetings. And Colleen and I will get that up probably Friday, because since we're just having our meeting today, I've got a little work to do now before we get that up, but we will have information available. So thank you for bringing that up. Other items that we want to talk about, I did put the election on the agenda, but we have a long ways to go here. So I think that could go to another meeting as well. Okay. Well, thanks. We went a little bit over our time today, but I think it was well worth it. I'm certainly going to send both Dr. Basil and Dr. Specker a thank you. They donated their time with us and expertise, and I just felt it was excellent to have that information and have their knowledge. So I'll follow up with them. If there's no other business, then I would look to either Dr. Milroy or Mayor Johnson to make a motion to adjourn.
I will make the motion to adjourn.
I will second.
Okay, all in favor to adjourn the health board meeting of Thursday, April 23rd, signify by saying aye.
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 Opposed, same sign. Okay, we're adjourned. Thank you, everybody. Please give things some thought. Let me know what you're thinking.
Okay. All right. Thank you.